everybody can hear me loud and clear. I'd like to welcome everybody once again to our COVID-19 Innovations webinar. For those of you that were able to join us yesterday, welcome back. If you are new to the webinar, we really appreciate your participation today. As we emphasized yesterday, sort of the reason for this webinar is for us at RUHS to share some of the innovations and best practices that we've been able to develop and deploy here at the medical center. We understand that many of you are facing the same challenges, the same questions as we work day to day through this crisis, and we were hoping we'd be able to share that with you and really collaborate as a county with our 17 partners, hospital partners across the county, and really to learn from each other, share ideas, and see if we can't tackle some of the challenges again that we are facing. Just to give a little bit of an overview from yesterday, despite some of our technical challenges, let's say, we had a very nice discussion on alternatives to the N95 mask. Here at RUHS, our respiratory team has developed full face BiPAP masks that are reusable. They can be clean, they can be passed on from provider to provider, and most importantly, we think they are safer than the N95 masks in providing protection for our staff. You can access that YouTube video if you did not see it already at the RUHS YouTube website, and that link should be in your chat box. So if you have an opportunity, please take a look at that. I think it provides a great explanation of what we are doing here at RUHS. We have, just so you know, are in the process of deploying 500 of those masks to our frontline staff, and it's been extremely well received. So before we move on to our new topic of today, again, just a little bit of a reminder through the presentation. If you have any questions, you can put those questions into the chat box. We'll also open the webinar up to video or voice questions, let's say. We'll sort of try to tackle those at the end of the presentation. Again, with these webinar series, we're trying to shoot for 15 to 30 minutes in total. So hopefully we can stay on target there. So today we have a great lineup here of our nursing leadership that will be talking about innovations within our ICU to help protect our healthcare workers and reduce our PPE burn. We have some of our strongest and what I would consider best nursing leaders here at RUHS that serve our intensive care unit. We have Tammy Lowe, Kim Hoyer, and Leah Patterson here with us. They have put in a tremendous amount of work to strategize around our intensive care unit, looking at ways to expand the ICU services in this anticipated surge, but also provide innovations to help protect our nursing staff and providers on the front line. So we really appreciate their involvement here, and thank you very much. I'm going to hand it over to our nursing leaders, and they will sort of give a brief introduction, and then we will jump into the YouTube video that was already pre-prepared, and then after that we'll jump into our Q&A session. So without further ado, here we are.
Hi, my name is Tammy Lowe. I'm the clinical administrator for clinical care here at RUHS. ICU coordinator. So today the topic today is going to be how the ICU reduced their PPE use, our surge plan, and implementing clinical processes during crisis. So I'll let Kim speak a little bit on that, and then we will watch the video.
So I think we're going to discuss extension tubing, some of our cross-training plans, and limiting PPE for our staff in the ways that we've done that. I think we're going to watch the video first, right?
Yeah.
Okay, so first up, the video.
Early on, we combed the literature, physicians and nurses, as I said before, collaborated on ways that we could preserve PPE, keep our staff safe, in doing so following CDC guidelines. When we decided to cohort our patients early on, before we started receiving patients, we have 2 separate ICUs. So we basically moved the surgical intensive care patients over into the medical intensive care patients, and we isolated our surgical intensive care unit for it to be our COVID unit. And so that's dedicated to our COVID patients. Then we expanded out into pre-op holding, where we created 7 more ICU beds for our medical surgical ICU patients should we have to grow our COVID ICU and return back into our larger ICU. Then our medical and surgical intensive care patients would then move from the pre-op holding ICU that we created into the anesthesia recovery unit, which is a 16-bed unit. And then if we need to expand our ICU even further, we're going to overflow into a connecting unit that now houses our non-critical care COVID patients. We disseminate N95 masks in a specific number to each nurse. So we kind of looked at our mathematical values of how many masks they might need per day. We're encouraging them to have continued use of their masks in the COVID unit of their N95 masks, but if they are damaged or soiled or need to be taken off when nurses go to break or lunch or break in the afternoon, that they take their mask off and dispose of it. So we've reduced our number of mask use by individual N95 use by maybe by 75% of what we started with in the beginning, just looking at the updated literature. We also were looking at how could we minimize the time that nurses spent in the room. So we came up with some creative ways, like other hospitals have done as well, in connecting extension tubing to our IV pumps and putting the pumps outside of the room. Many of these patients are very critical and they're on multiple drips. And so the nurses were spending more time going in and out of the room to address pumps than really they needed to, so they can handle a lot of those situations outside of the room. We also set up donning and doffing stations because doffing is one of the number 1 ways that healthcare providers are cross-contaminated with the coronavirus. We're very strict. We have signage on the doors so that the nurses can see the doffing and donning practices be appropriate. We set up some videos and sent out to all of our staff so they could refer back to doffing correctly. And we also huddle at the beginning of every shift our emergency practices, just in case a patient goes into cardiopulmonary arrest or has an airway issue. So we've implemented processes for that. And to remind staff, if you see something, say something, watch each other, but the buddy system of doffing so that we can keep everyone safe. The hospital has graciously given us hospital scrubs, so the nurses are able to come in, change into hospital scrubs. They've provided lunch and also for the nurses to wash down with CHG before they put their clothes on at the end of their shift.
Okay, so sorry about the audio issue. We're going to work on that, and then we will hopefully bring that video to you or put a link so that it can be viewed. So we're going to talk about some of the content in that video, which was our surge plans, our PPE challenges, and then implementing extension tubing for continuous infusions. So I'll go over the extension tubing for continuous infusions. So that wasn't our innovative idea, but it was all over social media. So our staff brought that up and we wanted to test it for efficacy and safety. What we did was take the extension tubing that we have. It's only like 40 inches long. And we daisy changed a couple of those after reaching out to the reps and asking for any position statements on that. And then we considered infection control practices. We wanted to make sure it was still effective, so we tested it in an empty room, found that there weren't any issues. We walked through the medication administration process with our staff and with our medication safety team. And then we looped in pharmacy just to get their insight and buy-in from the bedside medication scanning practices. And we also spoke with infection control just to get all the experts buy-in on what we should consider. And with that, we came up with a practice that we discussed with our staff, considering very strict hand hygiene in between accessing those pumps, and then not allowing any of the tubing to go on the floor, things like this. And it's worked out really well. We do have some inclusion criteria just for patient safety, that patients who are ambulatory would not be a candidate for this. And it's worked out well. So medication administration, at least in the ICU setting, is at such high of a frequency that we were burning through hundreds of masks and PPE every day. And this has brought us down to a fraction of that. So staff were able to titrate medications, start secondary infusions, and then we've expanded this to, if needed, administer push dose medications with using the extension. So I think a huge win is that we're decreasing our PPE burden, but then we're also empowering our staff and limiting their contact with positive cases so that they can still function from outside the room for just quick things like rate changes and things like that.
The surge plan, early on, we have a great group of physicians that we work with, pharmacists, respiratory therapists. We meet, a clinical advisory group meets every day at 2 p.m. to discuss all of our processes. So early on, we realized we were going to need a surge plan, a really effective surge plan. So about 3 weeks ago, we have a medical intensive care unit that has 24 beds and a surgical unit bed. So we moved all of our surgical and trauma patients over into our medical ICU, and then created a COVID ICU in our surgical area. Then we forecasted out where are we going to need to move should the need arise, which we all are kind of thinking there's a wave that's going to hit us. So then we decided to move into our pre-op holding area. We created a 7-bed ICU there. From there, we will move to the PACU. Those will remain clean or quote clean ICU patients. And then our COVID ICU, if we expand back into our 2400 unit, will then move into our step-down unit, which is connected to our medical intensive care ICU. Creating clinical processes during this crisis has been imperative to provide the highest level of care to our patients and support our staff. So the clinical advisory group that meets every day is very collaborative. They're combing the research. We're looking at papers published from from China, from Italy, from New York, Washington daily. And this close collaboration is, I think, very special and unique to our institution. And it's been proving to be very successful so far.
Education so that we can bring additional staff into the unit. So our education department has created like a template for all staff who are coming back into the clinical setting. And then in terms of ICU specifics, right now, repurposing some of our historic education for these potential frontline users. And then we're keeping a close pulse on the AACN because they have a comprehensive training that they anticipate in the next couple of days will be available through Elsevier if you use that software program. So that way, from a regulatory standpoint, you can use that as an education or competency people getting retrained or taking a higher acuity patient than they might normally. Some of the challenges in planning surge has just been working with all the partners to identify and strategize our highest priority. So our pharmacists have been excellent to add Pyxis programs throughout the hospital where we plan to surge that are built for ICU, and then staffing equipment. One thing that's been really valuable for us is to take our frontline staff through these surge areas and ask them to take a critical look at the space and give us feedback for what's missing, how we can do it better. And that's given us a lot of content to work off of to operationalize surge areas.
Well, that's not that good.
No. Physicians came up with, again, social media helped us with this, is creating a plastic box to help the staff stay safe during intubation. So created, I think we have 8 or 10 boxes now to use in emergency intubation situations and controlled intubation situations where COVID is either positive or suspected. The full face BiPAP mask, one of the challenges that we ran into there is there are staff that wear glasses that would not be able to be fit tested for those. So we're actually using the partial BiPAP masks for those clinicians that can't be fitted for the full face. The full face and the partial BiPAP have also reduced the irritation and abrasion of the clinician's skin from wearing the N95 mask in their ears and across their eyes. That's really helped reduce that. Most of the staff saying that it's much more comfortable and they feel safer with those masks as well.
And we just want to encourage if there are any questions, you can type them into the chat box and we'd be happy to answer anything specifically.
The green one. It looks like the one you put over here.
This is Dr. Thompson here. A question came in reference to the tubing and having the pumps outside of the room. Would you be able to estimate the reduction in time that the nursing staff is having to spend inside the room with that intervention?
So time is definitely our most valuable measure. In the ICU setting, nurses can be titrating medications as frequently as every 5 minutes or every 2 minutes. So the time saving is exponential, upwards of hours of their shift donning and doffing, because we know that our current workflow in the setting of isolation is that, and just practice is ICU nurses are entering the room at a high frequency, regardless of isolation status, to adjust medications, manage sedation, manage hemodynamics. So that they're able to, as quick as do hand hygiene for 15 seconds, review their orders, and then titrate their medications outside the room. And if I had to give it a number, I'd say they're saving hours of time on each option.
We're not doing that here, are we? Well, that's what we're gonna summarize. So far, what I like.
Another question that came in. You described some of the impressions that your frontline nursing staff are having with some of the interventions. Can you tell us some of the feedback that you have been receiving? And I guess in general, is there a solid reception of the changes that you've implemented? And do they feel that the interventions that you're providing is providing a safer environment for them to work in?
So
these kind of things. Time for everyone in healthcare. And we're in a generation where people are seeing what's happening all over the world, minute to minute. I actually just had a traveler this morning that has years and years of experience come to me and say, thank you so much for all you're doing. I'm so impressed. I know that you care about us and that you're working basically day and night to try to come up with innovative ways to help keep us safe. You know, there's still fear because this is the unknown, but creating that culture of trust and transparency with your staff is vital. And Kim and I have really spent hours and hours with our staff on the front line to show them that we're there to support them and that we'll go to the ends of the earth to try to come up with innovative ways to keep them safe.
Ways that we do that are at the beginning of the shift in our cohorted unit where our COVID persons that are positive or under investigation. We'll go through the donning and doffing at the beginning of the shift. We'll talk out if there's going to be an emergency on the shift, how we're going to respond to that. And we encourage a buddy system for doffing so that there isn't that risk of transmission when they're doffing. So that's really empowered a lot of teamwork on the unit, that they feel like they have each other's backs. It's not just nursing, it's our physicians who also reach out, can you watch me doff to make sure I do this correctly. So that's been really positive on the unit. Thank you.
Another question that's come in is with respect to negative pressure rooms. Some units have dedicated rooms to negative pressure. What have you done in the ICU to try to expand the negative pressure isolation?
So we worked with administration and biomed plant ops department, and the response was really actually very quick considering the situation. And we converted both actually 3 units, our smaller surgical ICU of 12 beds, our 2400 ICU, and our 2500, which is our step down unit connected to the 2400. All of those are now actually negative pressure rooms. So some of the challenges are that staff forget that they have to keep the doors closed. So it creates a bit of wind tunnel going in and out of the department. But it makes staff feel safer. And then we're able to provide difficult cares in a more safe environment.
If there's other questions, I don't see anything on the chat line. If anybody has a question, you can go ahead and unmute your computer if you like, and go ahead and ask the question.
How you process of dealing with COVID patient in OR?
I'm having trouble hearing you if you are asking a question. Okay. I'm not hearing any feedback there. I think the discussion here has been excellent. Again, we apologize for the technical challenges we're having with the video and the sound. I do want to emphasize that in the RUHS YouTube website, that the link is attached within the chat box. You will be able to access this video as well. So both the N95 as well as the ICU Innovations YouTube video. So at your leisure, please have a look at that. They've done again a fantastic job putting that together, and we hope it's ultimately useful on your end. Again, we've implemented a lot of interventions that we will hope provide a lot more safety to our staff during this time. So thank you very much.
We have a question. We have a question in the chat.
Oh, please. Thank you very much. Go ahead and voice that if you could.
This is from Liz. It says, OR COVID patient, how is your process for these surgeries and transfers to ICU?
So currently, I won't speak on behalf of our anesthesia partners, but my understanding is that currently the Anesthesia Society is advising to treat all patients as that they could be COVID positive. So I know our OR teams are utilizing full PPE and treating all patients like they could be positive. And then in terms of transporting through the hospital, there's a lot of considerations to be made, but we just look to mitigate any infection control risks. So if the patients are being transported with intubation and they have an endotracheal tube, then they have filters in line with either their transport vent or their BVM that is protecting that exhalation process. And then also we put just even a sheet over that transport vent just to limit any aerosolization or any exhalation. So the patients are then transported into the unit, and then we've just been training our staff on the concept of scene safety, that you go into the room with full PPE and that also is only as many as necessary into the room. So the staff get good communication from our OR team. They're donned in their PPE, and then they're ready to receive those patients.
OR has also been converted to negative pressure as well.
I hope that answered your question. Are there any others out there?
Gary, I know we're almost out of time, but I wonder if any of the other sites that are on the phone have any things that they've implemented that we might be able to learn from.
Yes, so Mike, those are great questions. And as discussed previously, we like to have sort of a two-way exchange of ideas through this webinar. Some of those are a little bit challenging, I know, from a time perspective. So we've emphasized that if there are any ideas, any thoughts out there that are sort of innovative on your end, we'd like to also share that with others. So via email, I think we have an email address assigned to this webinar that we can utilize for exchange of ideas, and then we can disseminate that out to our partner organizations. So thank you for the question, Mike. So yes, we are now at the half-hour mark. So just being respectful of everyone's time, we'll go ahead and close this webinar. Again, we'll be carrying this webinar on in the subsequent days during the week. Tomorrow, there will be some discussion about splitting ventilators. I know that's a bit of a hot topic, somewhat controversial topic, so hopefully we can provide some insight into that. On Thursday, we're going to be talking about curbside pharmacy services. Then we'll carry on from there as topics come up. So thank you again for your participation here, and just want to express to everyone to please stay safe and keep up all your good work. Thank you very much.
Thanks, guys. Great job.